My topic for paper presentation is left atrial volume as a risk stratification factor in patients with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a genetic disease of the myocardium, which occurs as a result of mutations in genes encoding the protein components of cardiac sarcomere, which is characterized by marked hypertrophy of the myocardium. Fibrosis and increased extracellular collagen in HCM hamper the elastic properties of the myocardium. It impairs the relaxation and increases the stiffness of the myocardium. These changes lead to diastolic dysfunction. As the severity of LV diastolic dysfunction increases, the LA pressure increases, consequently leading to LA remodeling and the LA cavity dilates. The physiological function of left atrium is it basically modulates the left ventricular filling. It is highly dynamic and responds to stretch with the secretion of atrial natriuretic peptides. It acts as a barometer of diastolic function. Left atrium size as a prognostic imaging biomarker and bellwether of many diseases such as hypertension, heart failure, stroke, and various cardiomyopathies. Left atrium measurement. Various methods have been used, such as AP diameter, area and four-chamber, volume by ellipsoid method, single and biplane area length formula. Size is better reflected by measurement of volume rather than area or linear dimension. Increased left atrial volume is linked to diastolic dysfunction and also adverse outcomes in HCM. LA volumetric functions offer additional insight into left atrium mechanics and provide valuable prognostic information. Primary hypertrophic cardiomyopathy encompasses increased risk for arrhythmia, heart failure, and sudden cardiac deaths. Atrial fibrillation is more prevalent compared with the general population, typically affecting approximately 20% of patients with HCM. The aims and objectives of my study are to explore the left atrial index volume in patients with cardiac magnetic resonance imaging, features of hypertrophic cardiomyopathy, to evaluate if LA volume can help to predict severity of disease and help in risk stratification. It is a retrospective study done in LDMMC Sion with a sample size of 25 patients. Data was collected over a period of 1 year. Patients with HCM who underwent cardiac MRI during this specific time period were taken into the inclusion criteria. Patients with chronic atrial fibrillation, other arrhythmias, prior stroke, permanent pacemaker implantation, and poor imaging were excluded. The image acquisition and interpretation. All the CMR examinations were performed on 3 Tesla scanner using a phased array body coil, and patients were confirmed by electrocardiography if they were in sinus rhythm. All the sequences were acquired using prospective cardiac gating. Analysis and post-processing was done. We then delineated endocardial and epicardial borders of left atrium, excluding the pulmonary veins and left atrial appendage on the 2-chamber and 4-chamber long axis images at the end ventricular systole as the reference phase. We propagated the contours of the LA wall with precision. LA volumes were calculated using the biplanar method and then proportioned to the body surface area at the end ventricular systole, excluding pulmonary veins and left atrial appendage, in 2 orthogonal planes. The formula for this is 0.85 into the 4-chamber area multiplied by the 2-chamber area divided by length. Otherwise, we directly have this software. Left atrial volume as indexed to normal body surface area. The reference normal range is 16 to 18 ml per meter square. Mildly abnormal, moderately abnormal, and severely abnormal have been graded. My results were, in males, 5 patients were in normal range, 4 were in mildly abnormal range, 1 in moderately abnormal range, and 11 in severely abnormal range. In females, there was no patient in normal range, 1 in mildly abnormal, 1 in moderately abnormal, and 2 in severely abnormal. This is a graphic representation of the same. The types of HCM that we saw, 11 patients presented with asymmetric septal hypertrophy, 2 with mild ventricular hypertrophy, 7 with concentric, and 5 with apical. Eight patients on follow-up, 8 patients presented with no symptoms, 2 were sudden cardiac deaths encountered in a period of 1 year, 2 presented as congestive heart failure, 7 patients, which is a whopping 25% patients, presented as atrial fibrillation as an outcome, and 6 were lost to follow-up. This is the tabulated form of the age group of the patients. Left atrial diameter has consistently been identified as a strong predictor of AF development in HCM patients. It has been suggested that the extent of atrial remodeling and therefore the risk for AF might be better reflected by 2D assessed LA volume rather than unidimensional LA diameter. So what was already known to us in patients with HCM, accurate risk stratification for AF is crucial, as this arrhythmia, being more prevalent than in general population, increases the mortality risk and thromboembolic risk independently of known risk factors. Increased LA diameter determined by two-dimensional echo has been correlated to occurrence of AF in patients with HCM. This is already known to us. So what this study adds was LA diameter and volume all independently relate to new onset atrial fibrillation in HCM patients. Overall, 50% of HCM patients develop new onset AF despite preserved baseline LA diameter. Both LA volume and strain improve prediction of new onset AF, particularly in subgroup of patients with preserved LA diameter, and may therefore be preferred over diameter for risk stratification. CMR is a promising method for quantification of the LA morphology and function in patients with HCM. This method allowed us to use values that were acquired using standard 4 and 2 chamber LV views without the need of extra acquisition and extra breath holds, which can be challenging for some clinical patients. Patients with hypertrophic cardiomyopathy demonstrated LA enlargement. Though long-term follow-up was not available, there is a strong possibility of unfavorable outcomes. HCM patients who developed AF are vulnerable to symptoms, impaired exercise tolerance, hospitalization for heart failures, and importantly known to have worse prognosis. AF increases by fourfold the risk of mortality, independent of other risk factors. It also increases eightfold the risk of thromboembolism. Early mortality or persistent neurological disability are also common in these patients. Therefore, accurate risk stratification for new onset AF in HCM patients should be a priority and may have an impact on follow-up and management strategies. My conclusion is LA volume index is independently associated with adverse outcomes in HCM and provides additional prognostic information. So it should be considered as one of the factors in risk stratification and prognostication. Thank you.